Everyone, my name is Harrian Won. I'm a gynaecologist, laparoscopic and robotic surgeon here at Prince of Wales Private Hospital and Royal Hospital for Women. Today I'm going to talk about endometriosis, and I'm going to focus on two learning outcomes. Firstly, to identify and dispel the myth and misconceptions about endometriosis, and secondly, to predict pregnancy rate using endometriosis fertility index. With an estimated prevalence of 10% in reproductive life, endometriosis affects 176 million women worldwide, and some 730,000 Australian women have endometriosis. Healthcare and productivity loss due to endometriosis-associated pain symptoms cost in excess of $7 billion annually in Australia, and it really has been quite underestimated as a serious burden of illness to society. This is what normal pelvis looks like, except this lady had a very large dermoid cyst. Please ignore that, but she has a beautiful peritoneum. Pouch of Douglas is patent. Ovary on this side is normal with a normal looking fallopian tube. It's really quite a beautiful pelvis. And compare it to someone with bad endometriosis, with dense adhesions, rectal adhesion to the posterior uterus, and it really is quite inflammatory and anatomically destroying disease. Endometriosis, by definition, is a presence of endometrial gland and stromal tissue out of the uterus, usually in the pelvis, but it can be found elsewhere. And it can look quite different, like this black lesion or white lesion, and deep infiltrating nodules, such as this in the uterosacral ligament or over the uterovesical fold. So the most common symptom of endometriosis, of course, is pain. They usually present with dysmenorrhea, dyspareunia, typically with deep penetrative intercourse, or with chronic pelvic pain, or dysgeusia. This is painful bowel movement during period, or dysuria or urinary frequency, again worse during menses. But 30 to 40% of women have infertility, and this may or may not be their sole symptom. And some women also have chronic fatigue or abnormal bleeding associated with these symptoms. And of course, some may have none. So let's go into some common misconceptions or facts. Are they myth or fact? So firstly, you're too young to have endometriosis. Well, we know that it affects reproductive age women with a peak prevalence of 25 to 35 years of age. Until 1970s, it was really thought to be a disease of women in their 30s or 40s because they had the pain bad enough to warrant a laparotomy. And it was thought that it needs many years of menstruation to develop endometriosis based on that. But we have to remember 2/3 of adult women with endometriosis report the symptom onset before the age of 20. And with availability of laparoscopy, it has allowed us to make the diagnosis of endometriosis much easier, including in adolescents and young women in their early 20s. So please be aware of a possibility of endometriosis, even in teenagers and young women in their early 20s, particularly if they present with a strong family history of endometriosis. I'd like to share with you a patient of mine who is 17, who presented with dysmenorrhea and dysgeusia. And after clinical and imaging suspicion of endometriosis, she underwent laparoscopy with a finding of stage 4 endometriosis. So she had a very large of the ovaries on both sides. We call them kissing ovaries because they're so large, filled with endometrioma on both sides, that they meet in the middle to kiss. And both fallopian tubes were quite distended and clubbed, as well as the rectum being involved with endometriosis. It has been reported to present in even pre-menarcheal girls as young as 8.5, and also 2 to 5% of postmenopausal women have endometriosis. Whether this is a residual disease from their reproductive years, or whether this is due to the use of menopausal hormone therapy, we do have to keep in mind that young women and older women can also suffer from endometriosis. So you're too young to have endometriosis? It's a myth, really. Let's move on to the second idea. Pregnancy will cure endometriosis. We know pregnancy increases progesterone, and this leads to desexualization of endometriosis, leading to less inflamed disease. Hence, your pain improves. But symptoms of endometriosis are likely to return when pregnancy and breastfeeding finish and when hormonal cycles return back to normal. So really, during pregnancy, endometriosis becomes less active rather than being cured. And it is rare, but there are reported cases of pregnancy complication from endometriosis, such as bowel perforation or ruptured endometrioma, although it is really quite rare to see that. So, will pregnancy cure endometriosis? No, but it will make it much better, at least transiently. Third idea is mild pain means your endometriosis is mild. It is quite well acknowledged that the symptom severity does not correlate with disease severity. Women with most severe endometriosis may have no pain symptoms at all, but to present with infertility only. Whereas some women with absolutely horrible pain may be found to have only very mild endometriosis. Why is this? Because endometriosis pain is very complex. It is composed of nociceptive pain from damage to non-neural tissues, and this includes inflammatory, or it can be neuropathic, pain from somatosensory system, or it can be in combination of these. Furthermore, the pain perception is influenced by other factors such as psychological stress, physical stress, or hormonal changes and coping mechanism. So, mild pain doesn't mean that your endometriosis is mild, and also severe pain doesn't mean the endometriosis is severe. Next idea is, will endometriosis increase risk of cancer? We know that endometriosis is a benign condition, but it is interesting in a way that it behaves like cancer. It invades the local and distant organs, and it causes abnormal tissue growth. It impacts the target organ function and causes genetic damage. And it has been published that endometriosis is associated with particular subtypes of epithelial ovarian cancer, including clear cell, endometrioid, and low-grade serous epithelial ovarian cancer, but not high-grade. And having an endometrioma in the ovary seems to be a risk factor for this. But let's be clear, most women with endometriosis do not develop cancer. The general population, there are 1.3% lifetime risk of developing ovarian cancer, which is 1.8% in those with endometriosis. So how do we use this to counsel women who is sitting in front of you in your consult room with endometriosis when she asks, so am I going to develop ovarian cancer, doctor? There was a recent article in Lancet published just a few years ago addressing this very issue of how do we best counsel women about their risk of ovarian cancer. It's just that most women with endometriosis will never develop ovarian cancer. Thus, you should be really aware of but not worried about the effect of endometriosis on ovarian cancer risk. Certain types of ovarian cancer are more commonly associated with history of endometriosis, and these tend to be detected at an earlier stage and have better prognosis than other types of ovarian cancer. So, doctor, what can I do to lower my risk? Well, there's no real clear evidence for using routine screening transvaginal pelvic ultrasound or serum marker CA125 or doing prophylactic oophorectomy in women with endometriosis. So endometriosis does increase the risk of ovarian cancer, but very, very slightly. The last idea is endometriosis causes infertility. I think we've already touched on this. Women with infertility, 30% of them have endometriosis. And there are 10% of women from general population have endometriosis, and of those, 30 to 40% do have infertility. How does endometriosis cause infertility? Well, increased macrophages and cytokines in the pelvic cavity increases inflammation, leading to decreased sperm motility and impaired fertilization and embryo transfer. It also causes tubal damage and adhesion. And in the uterus, activation of aromatase and steroidogenic factors leads to release of progesterone, resistance to progesterone, and production of estrogen, which then alters the endometrium as well as the myometrial contraction, making it just not a very nice, pleasant environment for pregnancy to occur and implant into. In the ovaries, presence of endometrioma and having surgery to ablate or remove part of the ovaries reduce functional ovarian tissue, which then impacts the fertility. But the actual effect of endometriosis on oocyte quality is not very clear. So this is how endometriosis causes infertility in 30 to 40% of women. So endometriosis does cause infertility. And I want to move on to the next learning objective, which is about endometriosis fertility index. It was first published in about 10 years ago, and it is really a scientifically derived index that predicts pregnancy rate in endometriosis patient who wants to get pregnant following a surgical assessment and treatment of endometriosis. It is first of its kind, and it's particularly useful in counselling women after their surgery about their fertility. It has been derived from more than 20 years of clinical data, and since in the last 10 years, it has been validated by more than 15 studies. It's really quite helpful in counselling women and developing a treatment plan after their surgery. Unfortunately, it's not very useful in predicting the progression of pain symptoms. So this is what it looks like, and at the conclusion of surgery to remove and treat endometriosis, we give a score for fallopian tube and fimbriae and ovarian function at the end of the surgery, both on the left and the right side, and then we work out the lowest score and add them up together to work out a least function score. And we work out the EFI score first half is based on historic factors, so how old are they, how many years have they been infertile, and whether or not they had any previous pregnancy. The second part is the surgical factors, so the least function score that we just worked out previously. And to this we add the American Fertility Society endometriosis and total score. And then we add these two scores together to work out the EFI score. And the EFI score ranges from 0 to 10, where 0 representing the poorest prognosis for pregnancy, and 10 is the best prognosis. The score is then converted to the percentage of pregnancy over the time, and this is for next 3 years. And this pregnancy rate does not include IVF, but it includes non-IVF treatment pregnancy, such as ovulation induction or intrauterine insemination. So let's apply this to a real case. So Miss NB is a 36-year-old nulliparous woman who presented with the typical symptoms of endometriosis. So dysmenorrhea, dyschezia, urinary frequency with menses, and she was keen to start trying for pregnancy soon. With clinical and imaging suspicion of advanced endometriosis, she underwent laparoscopy to find stage 4 endometriosis. Rectum was adherent with obliteration of pouch of Douglas. Ovary on the left and the right side had endometrioma, which was quite densely adherent to the posterior uterus and pelvic side wall, and there were deep infiltrating disease in the posterior pelvic compartment. And the left tube looked a bit distended and slightly dodgy looking. So based on this, we treated it and then gave a score on the left side for the fallopian tube, fimbria and the ovary, and picked the lowest score, which was 2, and then did the same on the right, which was slightly better, but the ovary having been quite stuck and it had an endometrioma, it still scored 2. So to add them together, the least function score was 4. And based on history, she was 36, and she's actually hasn't tried for pregnancy, and she hasn't had any previous pregnancy. So historical score, she got 3, and surgical score, she got 2. And adding 3 and 2 together, the total EFI score is 5. Now this is all very numbers and numbers, but if we plug it into our calculator, this is what we can present to the patient at the end of the surgery. So at 6 months of trying, our estimated percentage of pregnancy is 12%. At 12 months, it's estimated to be 22%. And at 24 months of trying, it'll be 39%. So it is really quite a simple and robust and validated clinical tool that predicts pregnancy rate for pregnancy after surgery. It really is quite helpful for the patients to see where their fertility is sitting, and it helps us to determine whether do we let them try for pregnancy naturally or whether do we consider other assisted reproductive techniques earlier on rather than later. It'll be really nice, and further efforts are required to develop similar staging system that will help predict outcomes for patients with endometriosis and pelvic pain for both surgical and non-surgical treatment. But that's yet to come. So I'm very happy to take questions, and there is a little section in the webinar panel on the right-hand side. If you can write your questions, I'll be more than happy to answer your questions after Dr. Jason Chow's talk. Thank you very much for listening, and if you have any questions, please feel free to contact me. Thank you very much.
Thank you very much, Dr. Wong. And now Dr. Chow will be speaking on endometriosis, speaking on non-endometriosis pelvic pain.
Good evening, and thank you very much for the opportunity to chat with you tonight. And it's nice to be able to synergistically speak with Dr. Wan, with Hariam, but hopefully I'm going to give a little bit of a different perspective. Usually when I give these talks, I like to be a little bit spicy, although my cover slide's a little bit bland there. And usually when I've given talks to the group previously, I've been able to screen the audience and tailor what I talk about according to what you guys do. So this is a bit of a different format, and I have given similar talks in the years past. So I've tried to do things a little bit differently tonight, but happy to run through other details as we go or in the question time. So one of the big questions that I ask, and a lot of ask, is, you know, endometriosis and pain, as Harrian explained, are not necessarily correlative. So why do we operate, and what's the basis that we operate for pain? And we found that there is a benefit for pain management when you operate on superficial peritoneal endometriosis. That's the smaller endometriosis, or the superficial stuff that Dr. Wong's been talking about. However, this is really based on 3 randomized controlled trials, about 170 patients. That's driven a lot of our evidence over more than a decade. Only 2 of the studies have looked at 6-month outcomes and 1 at 12-month outcomes. And the rest of the data we have is really from surgical case series observational data, which isn't really as helpful. And so Professor Horn, who is a gynaecologist, is going to host the World Endometriosis Society's meeting next year, COVID providing, asked this sort of question: is, you know, should we be operating, and what's the basis that we should be operating as really the sole management, or as a large part of our management for endometriosis? And really his conclusion, which is a very surgical conclusion and not an unwise one, is, you know, we should be having this sort of big RCTs to really look at what we're doing. But I ask it from a different point of view. And so I'm a gynecologist, but also a pain specialist, and I put my pain specialist hat on. And what's really surprising is we've probably got about 3-4 decades of data mixed between human and animal stuff that really looks at the neurobiology and the neuroscience behind why women get pelvic pain. And the answer is not all about endometriosis. We know that 10% of women have endometriosis, but 20 to 25% of women have chronic pelvic pain. We also know that women who have surgery for endometriosis, a lot of them have ongoing pain. I mean, you know these stats from your own practice as well. 20 to 30% of them in some of those RCTs that I mentioned have no reduction in their pain. And a lot of them have recurrent symptoms, whether you treat them with surgery or hormones at the time you cease the treatment. As Harrian said, the stage of endometriosis doesn't correlate with the pain. And we also know that there's diminishing return with repeat surgeries. In some case series, by your 4th laparoscopy, only about 40% of patients may have a benefit from a pain management point of view. So without reiterating, again, these are all more superficial sort of looking disease. Some of it's deeper, but the left-hand side images are superficial. And this is terrible stage 4 endometriosis, where the bowel is completely stuck up to the back of the uterus. And the surprising thing is this lady with stage 4 endometriosis didn't have much pain. She presented with infertility primarily. And so when we think about endometriosis, what I want you to start thinking about is about the whole person. It's not just about these surgical lesions or these endometriotic lesions in the pelvis. So you may recognize this as Frida Kahlo's broken column portrait. And I think it's a really good representation about how the person, how the woman feels. She has had big spinal surgery, and she was in a metal brace, I think, for several weeks after the surgery to help manage it. And you can see her defiance, but the tears, the nails in herself, and the visualization of what she sees her spine to be like with the ionic column. So I hope tonight that we'll run through, in that setting, a little bit of the neurobiological mechanisms in pelvic pain, but more importantly, to look at the mechanisms of pain as the basis for our management. And also to consider that there are other things that cause pain. And I'm going to briefly mention some of those things, in particular, some of the peripheral nerves that can contribute to pain in the pelvis as well. So when I've previously given this talk, you may have seen this. This is from a neuroscience group called Strassen and Berkeley. And I used to always say, look, this is the image I looked at when I think of women with endometriosis and pain. Maybe not as illustrative as the Frida Kahlo example, but talking about this on a Thursday night might make you put you to sleep. And if you're otherwise inclined, it crosses both divides of politics. So I'd want to put to you that pelvic pain is not just about the pelvis. And the first thing I want to mention is that visceral pain begets visceral pain. Now, this is a little bit of a loose license with the neuroscience, but there's this concept of something called visceral hyperalgesia. And there's a couple of decades of stuff that looked into this. There's an Italian lady called Gira Borodino, and she looked at a few of these mechanisms, and she showed that, for example, as you know, these women with endo, with dysmenorrhea, with period pain, have IBS, and if you treat the IBS, it also improves their period pain. If women have urinary symptoms, if you treat the endometriosis, it improves that, whether that's by hormones or by surgery. And we know that also urinary lithotripsy, so if you have a renal calculus, that also improves your dysmenorrhea. Even more interesting is that dysmenorrhea or pelvic pain continuously actually changes your pain nervous system globally. So if you did pain threshold testing on your deltoid with a noxious stimulus, it's like a pin, and you control the circumstances, you will find that women who have had a lifetime of period pain are more easily going to feel pain than a woman who hasn't had a lifetime of dysmenorrhea. Completely different part of your body, and obviously not just to do with your pelvis. And these are just a couple examples, and I can go run through a lot more of the neuroscience over the last couple of decades. I'll leave this one here. But when you compare, for example, from functional MRI studies, and you compare women who have had endometriosis versus pain, the issue is the women who've had pain, whether or not they've had endometriosis, that causes the grey matter changes in their brain. And so this is reflected in the new ICD-11 classifications to describe pain. And one of the issues is that we can have endometriosis, but you can also have the diagnosis of chronic pelvic pain or chronic primary pelvic pain syndrome as its own diagnosis. And I know that's anathema to us as surgeons, and it's anathema to us who think about, looking for a cause of pain, and you get rid of the cause of pain, your pain should get better. But what it's trying to reflect is the neurobiological mechanisms of women who have pain. So again, without boring you in too much detail, let's put that into practice. And what I'm going to try and show you is that our management should be mechanism based rather than just looking for causes and cutting them out. And I think, in essence, you are in the best position to do this, even before the referral, or to give guidance about how best to do the referral to the right people. And I think the other thing which I haven't put here is that putting the patient as the first central person in the decision making is the most important thing. Now, everything that Harren said is true though, and we've come through several decades also of people who don't validate endometriosis and have said, oh look, there's nothing, it's in your head, and so forth, and patients will tell you this as well. They'll also tell you any stories of the average age of being diagnosed with endometriosis is probably 5-10 years after they probably had symptoms. So it's important to validate their pain, but it's also important to educate and to explain that endo doesn't cause all the pain, and there are other ways to manage it. So one of the things I want to hopefully go through is how to identify and treat your triggers for pain, no matter whether there's endo or not, to explore other ways of managing, and one of the things to also reassure the patient is that looking at non-surgical management initially, whether or not there's endometriosis there, won't worsen their endo or their fertility, especially if you're going to look at it, say, over a few months as part of your trial management. So I'll give you a first example. This is Natalia. She's 28. She's had a bub before, and she's come with worsening pelvic pain, particularly with defecation and with sex. She has had previous stage 2 laparoscopy, stage 2 endometriosis and a laparoscopy about 4 years before she had her last baby. And she's come saying, look, I'd like a referral back to the gynecologist for a second laparoscopy. They helped me last time, want to do it again. So we take a bit of time to have a chat with Natalia. And one of the issues she describes, which is a little bit unusual, is that her pain started in the early postpartum, particularly while she was breastfeeding. And already Harren sort of said to us how during pregnancy, both from the decidualization of the endo lesions itself, but also with the suppression of estrogen sensitization, especially into the postpartum period, if the lady's been breastfeeding, often endometriosis-related pain is quiescent. So a little bit of an unusual factor. We hear that she is now a year and a half postpartum. She finished breastfeeding at 10 months, but sleep is still quite disturbed. And on the days that she doesn't sleep well, the night she doesn't sleep well, the following day she's a lot worse. We hear the cycles come back, and that's been a trigger for some for pain. But also, interestingly with the bowels, is she gets pain not just when she does the poo, but it can last for a couple of hours after she's finished pooing. And she has had a lifetime history of dysmenorrhea for menarche. Bit of social history is that through COVID, she's not been able to swim in the public pool that she usually does, and she can't go to the gym. So she's been trying to do some online classes, and she's doing a lot more sort of stuff which is core based, kettlebells and deadlifts and things like that at home, online. And usually exercise and swimming are really good mechanisms for managing her stress as well. Finally, she's keen to get this laparoscopy done because work's a bit of a threat, and she's going to be transitioning to a new role at work in 2 months' time. And now's the time to take time off if she needs to. So stakes are high. So what I do in the examination for someone like Natalia is I have a look at them, have a look at Natalia, not just from a gynaecological, traditional gynaecological approach in doing a speculum and a bimanual examination. I also like to look at things from a musculoskeletal point of view, and I'll run through that in a future case example in this session, but also to look at things from a pain assessment point of view. So one of the different things that I do is I often start the examination from a vulvovaginal point of view without doing the speculum, because I find that if a woman's already sensitized, then you will flare up their pain from the speculum, and that takes away information and gives you a false positive with your assessment afterwards. So the first thing I do for someone, particularly with a history of dyspareunia, is a cotton bud to touch over the vestibule. And this is different to using a finger because it runs with different nociceptors and different nerve fibers. So just because they don't have pain with a finger, examination with a finger, they may actually jump with a cotton bud with the examination. And that's just over the labia, but over the posterior fourchette as well. The other thing that was interesting is that she had not just pain and jumping off the bed with a cotton bud, but she also had overactivity of the pelvic floor. Now, this is not something we usually get taught how to examine. We usually just say, look, you know, we feel for cervical motion tenderness and we feel for masses. But actually, if you limit your examination, someone's got a lot of pain to a single finger, and that takes some practice. And again, that's to reduce false positives, because obviously if someone's very sensitized, a 2-finger examination is going to be more provoking than a single finger exam. But what I feel for is, instead of feeling with my, if the lady's lying on the bed in sort of semi-lithotomy, instead of with my finger upwards, I actually put my finger downwards and I feel over the pelvic floor. And if you feel that the muscles are bulky and if they're tender, that can be a bit of an indication that there's other stuff going on, including pelvic floor overactivity. And one of the other things that we look for is that when you do the speculum, you'll see this sometimes, when you try to open the speculum, you can't open it. It's quite difficult to open. And women who don't necessarily tolerate speculum examination very well, that's often because either got sensitization and allodynia, or they've got some pelvic floor overactivity, or both. As part of the assessment, you do send her for a pelvic ultrasound. There's a role to do very specific pelvic ultrasounds in endometriosis, and she certainly doesn't have any obvious deep endometriosis. It doesn't rule out superficial endometriosis, I acknowledge. But you explain to her, you say, look, you know, you've got a few risk factors here for having persistent pelvic pain. She's had lifetime dysmenorrhea, and she's also got some recent stresses. She's also had a few factors that lead away from a reason for having a flare-up of endometriosis, in that she's come off a long period of pregnancy and breastfeeding as well, and the pain started at the start of that time. So what are some things that we can look at around management? Well, Natalia's not trying to fall pregnant, so one of the important things is looking at hormonal management. And I'm not going to draw on this today, but I can talk about it in question time. But this is a crux of a lot of management for endometriosis. Surgery is one aspect, but it is a medical disease. It's a chronic disease, and hormonal management is really important. And if she can skip cycles on a pill, that is one good option. We can also talk about the Marita with her and a few other options. There may be a role for using topical neuropathic treatment, particularly because dyspareunia is a particular issue for her, and she's so allodynic. So as a group with you may have heard that we use this in different formulations, and one of the things I really find really frustrating with compounding pharmacists is they all have the same ingredients, but no one tells you what base they put things in. So I'm not going to give a plug for a particular pharmacy, but we've looked at some work looking at different formulations and specific bases, and I'd suggest things like Versa-based Organogel, and there are some other products that are commercial out there like Migel, M-I-G-E-L, and that's got a little bit of amitriptyline and a little bit of estrogen in it, and that can be quite helpful to reduce the sensitization locally on the pelvic floor and the vulva and vagina. You may want to consider sleep management, and it doesn't just mean neuropathic pharmacotherapy, but there may be a role to use a low dose of an oral tricyclic. But obviously with Natalia, you'd start with non-medication sort of strategies first. And then you can also look at specific pelvic pain-based physiotherapy. And this is different to the type of physio you would do after you've had a bub or for urinary incontinence, because it's not just about pelvic floor strengthening. It's about pain education. It's about learning to desensitize, so reduce that cotton bud allodynia response. It's about learning to downtrain your pelvic floor. So not just the strength and the contraction, is learning how to let go. And there's several ways you can do that. They do that from a very central mechanism point of view. They do breathing, diaphragmatic breathing. They may even get them to do their own examination and massage, or more passive physio where the physio does it for them. But the key is that they're giving the patient structures to be able to do it, rather than you need to keep seeing the physiotherapy for that management. And finally, looking at things like bowel management, because defecation is a particular trigger for NATALIA. There may be a role in a small subset of patients that are also to do things like, for example, Botox to your pelvic floor as a pain management strategy, and just to help as a muscle relaxer to help break that cycle. Now, I'm going to not go through this in a lot of detail, but I'm happy to, and look at other neuropathic pharmacotherapy. And this is more for general chronic pain, but there are some specific things, particularly in the setting of endo and chronic pelvic pain. The two things that have evidence are nortriptyline and gabapentin, and the rest of it is extrapolation from our other neuropathic pain pharmacotherapy management. But the key is for young women particularly, is you start low and go slow. So for something like, for example, like I usually start with nortriptyline, and I find that has a less side effect profile for women than the amitriptyline. Start with a half dose, so 5 milligrams, and every week you go up. So you go really slow. So it's going to take them a month to get to a decent dose. You get them to stop at the dose that helps them, and you don't need to go more than 50 milligrams. Anything above that, you're using it for mood and anxiety. You're really aiming for that low dosing for neuropathic pain. Likewise, gabapentin, duloxetine have a role. There are other neuropathics we'll talk about. Opioids, as you know, have a lot of issues. And I think if you're going to start this in this sort of setting, we've got to remember that it's not a great medication for visceral pain nor for neuropathic pain. Constipation is an issue when she's already got defecation-based pain. But more important than that, it's also, as you know, associated with the increased risk of morbidity and mortality. And interestingly, it worsens chronic pain because it turns on the neuroinflammatory mechanisms and sustains them. And some of those mechanisms are not reversible. Cannabinoids, I'm not going to talk about in detail, but I'm happy to take some questions about. The short answer is there is no evidence at this stage, but there is a dearth of any medication that looks at that sort of stuff. And also cannabinoids are throughout the genitourinary tract, as well as from a pain nerve system point of view across the brain and the spinal cord. So there certainly is a role for that pathway, but it's just not been looked at. The final question is that NATALIA, you've told all this to NATALIA, and she says, well, what about my endo? I'm really worried the endo's going to come back. I want another kid in a few years' time. I just need to have this laparoscopy. And I guess the thing you're going to take back is that, yes, getting individualized for NATALIA, she's really got this window from a work point of view to do her surgery. But at the same time, is there much harm in non-surgical management if you're going to look at this for 2 or 3 months? The other big question is that she might end up with worse pain after the surgery. And I'm sure you've all seen this. And I think part of it is that someone who is quite sensitized, and I didn't mention this in the examination, but if, say you did the cotton bud examination, you brushed a cotton bud or a tissue over her abdomen, or you did the point testing over her abdomen with the cotton bud and she jumps, you'll be concerned that this is someone who has got widespread sensitization, and you stick a scope in that, even if she's got endo, you remove it, she's going to have a far worse time managing that and recovering for her surgery. She may very well not be able to go to work in that setting either. The last thing I'd say is that let's discuss our expectation of outcomes from surgery. We know that 20-ish% of women don't get better from endometriosis surgery, and we said that there's diminishing returns from repeat surgery. I'm not saying there's no role for that. And the big question asked, and I wouldn't say this of any of the panelists tonight, having worked with them all, but one of the questions is, do us as gynecologists actually do this? How many of you gynecologists have actually said to a patient, you're not necessarily going to get better from surgery? I wager that majority don't. And in fact, I mean, I've got a skewed perspective because I often see the second, third, fourth opinions, but the classic story is that the patient says to you, I've been told, this is the answer to all my 10-year journey with pain. I'm going to have surgery. It's all going to be better. But clearly, there's much more to pain than just those surgical lesions. Now, my second objective to briefly go through, I've got time, is around peripheral neuralgias. And there's two I'm going to run through, the iliohypogastric iliinguinal and also the pudendal nerve. So I'm going to give you some illustrations as cases. Susan's 33. She had a Caesar as an emergency 8 weeks ago and has had left lower abdominal pelvic pain since that time. She's had previous stage of endometriosis. She's currently breastfeeding. And it's been suggested to her, look, I think it's time to do a laparoscopy. You're such bad pain. And we know you've had endo on your ovary before. Maybe we might need to consider taking out the ovary. And this is a true case. And when you ask Susan a bit more about it, she has pain, particularly when she flexes her, she flexes her hip. So when she's going upstairs, she's getting out of the car, getting out of bed. She carries a son on her left hip, and that's becoming more difficult. And she had a really difficult recovery from a seizure. Everyone said, oh, look, you're using too much opioids. You're still here at day 5. Get out of hospital. This is not the usual thing. We're going to limit the amount of opioid you have. Tramadol kind of helped, maybe a bit sick. That was the only thing that worked. And now I can't take that. And I'm really struggling at home. Now, importantly on that note, you would do obviously an assessment around how she's going from a first bud point of view. Is she sleeping? She got postnatal depression. How's she managing? Who are her supports at home? From a physical point of view, there's a few other things that I'd look at as well with her. So I'd look at whether she has a positive Trendelenburg. And one of the things I look at when I look at them posteriorly, look at the posterior pelvis and look at those PSIS. So what we're looking for as I lift up and down is you'll see some asymmetry with the PSIS moves. Your sacroiliac joints are supposed to move 2 to 4 degrees normally, so very subtle movements. But you will find that the PSIS sometimes stays steady or goes in the opposite direction, so it goes upwards rather than downwards on the side where women are lifting up their leg. And the other thing is that when you do an assessment of the abdomen and you look at that iliohypogastric and ileoinguinal distribution, so I'm just going to flip back up. So if you can see my cursor here, it's very demarcated. It will be to the midline and very demarcated in this sort of setting. And if you use just the back of a condom, but you don't even have to use a pin, and I'd probably ideally not to use a pin, you will find that they're allodenic in a defined distribution, or they have numbness in a very defined distribution. And finally, if you palpate with the finger on the left lateral rectus border, you're kind of trying to feel for where the nerves come out and pierce the abdominal wall and they have point tenderness. You probably land yourself a diagnosis of an iliohypogastric neuralgia. And it's quite common. It happens in some case series and up to 5 to 10% after seizures, but usually these things recover. But I'm always sus of the women that have unilateral neuropathic sounding pain, burning, cold sensation, they feel numb, and they have much higher pain requirements after their seizures, that there is a neuropathic component, and particularly iliohypogastric neuralgia. And this can be easily remedied if you do it in the first 3 months with an iliohypogastric block. Sometimes you need 1 or 2, but it's resolvable, and it's really quite a straightforward procedure. You can do it on an ultrasound, you can do it in rooms as an outpatient, or you can do it on the light sedation. The worry is you don't want to leave this for 3-6 months, because that's when the central mechanisms set in. And once that's happened, no matter how many blocks you do, they're going to have chronic pain and with central mechanisms. This is all non-evidence based, but anecdotally, some people use compounded topical neuropathics, so compounded amitriptyline, PEA, things like that. Some women use like a 5% lidocaine patch, Nervoderma vasatis, things like that. I know it's best for shingles, but it can be helpful, and obviously it's helpful in a setting of breastfeeding, where a lot of women don't want to use oral-based medications. But the other thing, which I think is probably more helpful, is that quite often for these women, you'll find they have predispositions, and they often have a little bit of pelvic girdle rotation. And so what happens with that pelvic girdle sign is a lady who carries a bulb on the left side. She's already got some positive girdle signs on the Trendelenburg. And what that does is they crunch down their abdominal wall all the time. And so if you've got a nerve that's already at risk of sensitization or of neuropathic pain, it's going to be crunched down between the abdominal wall because they're not using their muscles efficiently. And so physiotherapy orientated at that specifically, not usual back physio, not your pelvic floor physio, but that specifically can also be helpful to help minimize return of that pain. Finally, again, Susan's got the worry about endometriosis, but you can hear from the timing of the pain and also the fact that she's breastfeeding, it makes that sort of diagnosis much less likely. Now, if I can have your patients a little bit longer, I'll give you one more example about a peripheral nerve, and this is KATRIN. She's 52, she's perimenopausal, and she's got vaginal pain and aperinia over the last 6 months. She also has a previous history of endometriosis. Her pain's interesting. So KATRIN's winding down her work. She works for public service, and she's going to go to part-time. And in that part-time, she used to love cycling. She's joined a cycling club. So cycling's increased, and she probably does 240K rides a week now. And over the last 6 months, despite changing bike seats and so forth, she used to get really numb in the perineum, and now she has pain, which is a lot worse when she sits. And it's really very much just with sitting and not with lying down. She's become very distressed, and a lot of her friends are cyclists. That's her cycling club that she joined, and so she's feeling a lot more isolated around this. And there's a little bit of tension now with her partner because she's not able to have sex. And when you examine her, she has allodynia over the right labia. She has a lot of tenderness over her right pelvic floor muscles asymmetrically. And again, if you put your finger and point to the rectum rather than up to the cervix, down the rectum, and you feel back for that bone, which is the ischial spine, and you tap very lightly, and they have a lot of pain, that gives you a little bit of a clue that that's where the pudendal nerve comes out into the under the pelvic floor, and she's sore on that area. So this is a lady who's probably got pudendal neuralgia and may have pudendal nerve entrapment as a background. And again, a lot of the management is around pelvic pain-based physiotherapy. So you don't want to provoke that nerve by doing lots of squat, sit type stuff. Now that might spell issues for KATRIN cycling in the short term, and certainly she has entrapment potentially longer term, and so we have to work around that. There may be again a role for neuropathic-based pharmacotherapy, either topically or orally or otherwise, but to help you make the diagnosis and potentially treat it, you could again look at doing a pudendal block. And again, it's not a difficult block to do. We do it transgluteally because some of the branches come off above the ischial spine, so above the vagina, but different ways to look at that. I'm not going to go into detail today because there's fancy stuff that we do, like robotic pudendal release surgery. So you can see this is the nerve between the ligaments being released here. We do simulators, but I tell you, this is for the vast minority of patients. And the majority we manage conservatively to improve. Now again, validate. She is asking, is my pain real? She's seeing a gynecologist and he has said, you've got a normal examination. And she says, look, every time I see someone, they say, your examination is normal. But the thing is that, have you done that kind of exam? Have you looked at the pelvic floor? Have you looked at it from a neuropathic point of view, or are you just looking at the viscera? She's also been suggested to have a hysterectomy, but clearly by the history and the examination, also by the nature of the pain, and it's a perimenopausal woman, very unlikely endometriosis is going to be the trigger in this sort of circumstance. So I hope I've shown you that a little taste of the neurobiological mechanisms for someone with pelvic pain and understanding around that are really important. And if we can use our mechanisms of pain as the basis of management, and also consider some other causes like musculoskeletal causes and peripheral neuralgias, that's going to be really much more helpful in our global management of a woman with pain. Now, a couple of notes, some really few helpful resources I find. Macquarie Uni run an online pain-based education and CBT program. People can do the free course, but the paid course, which is $60 for 3 months access, so it's not excessive. I find a lot of our women find this helpful. Now, they've just changed the picture on the website to an elderly man, so maybe a little bit off-putting for your female patients. It used to be a woman, but a lot of women do give feedback, and the idea behind it is that the psychologist will actually email you or give you a call during your course while you do the work. And a lot of the work is about you orientating it to your own goals and outcomes. Second one is through the ONG College, but it's done by one of our colleagues in New Zealand who is both a pain specialist and a gynecologist as well as a committee, and they've looked at an e-learning module about endometriosis. But more important than that, it also covers around pelvic pain, and again, patient-centered care and true holistic management. Finally, the Faculty of Pain Medicine have a really good program around pain prescribing. So it's supposed to be large around opioids, but actually it gives a little bit of the stuff that we've been talking about tonight, which is, there's one thing just to say don't prescribe opioids, but another thing to say, well, how do you treat the patient? And best thing is that a lot of these things are free. So the Francois one as well as the Faculty of Pain Medicine one are free. I'll send these links out to you through the network as well at the end, so you don't have to scribble all this down. And hopefully you'll see that endometriosis is more this sort of picture rather than just the lesions in the pelvis. Thanks very much.
Thank you very much, Dr. Chow. It's now time for our question and answer session, and Dr. Wong will come back on for us. Okay, so I have quite a few questions here for you, so whoever prefers to step in and answer them, it would be great. So can recurrent bacterial vaginosis be a sign or cause of PID?
Jason, do you want to take that one?
Sure. Yeah. So you can. So I think there's two questions in there, or two answers in that. So BV, or bacterial vaginosis, can be associated with PID, but the issue of recurrent BV is I think a separate issue, and you don't necessarily have to have PID nor a lot of pain symptoms, if that's where that question was coming from. Recurrent BB, unfortunately, can be a bugger to manage, but a lot of it, a lot of the stuff out there is not evidence-based. I think that there is a role for sometimes for doing a prolonged course of either vaginal metronidazole or looking at commensal-based management, good vulval hygiene, so avoiding, washing into the vagina, avoid using any soaps, wearing cotton underwear, avoid using liners. There's no role for treating partners. And some women, there's some small studies that have said, if you go on to sort of preventive therapy, so either, for example, weekly boric acid or sometimes weekly metronidazole vaginally or things like that as a one-off dose once a week, and things like that, that may be helpful.
I also find with bacterial vaginosis that are recurrent, it may be something else other than bacterial vaginosis. So quite often screening for things like mycoplasma, using a PCR swab, or at times if there are suspicions for cervicitis or urethritis, checking for ureaplasma as well, often quite helpful, and resolving their symptoms as well, along with all the things that Jason mentioned, including hygiene changes and the simple moisturizing routine and so forth.
Thank you. Does every patient who has surgical intervention for endometriosis get an EFI score after surgery?
Thanks for the question. So it is only really helpful for those planning pregnancy. So let's say someone who's quite young, who has no real plans for pregnancy in the next 2-3 years, they wouldn't really require EFI score. But it is really targeting at those women who are undergoing surgery for endometriosis, who are planning pregnancy thereafter.
Re-endometriosis fertility score, why do you not use a comparison figure for someone the same age and fertility status who hasn't been diagnosed with endometriosis? Would this not inform a decision re-assisted fertility better?
So let me just clarify the question. So why do we not use age-based fertility? So for example, using AMH, which we get oocyte count according to comparing to other women of the same age? Is that the question? I suppose.
I can't assist you there, I'm sorry.
Of course. So it is difficult because different people will have different endometriosis and different history in terms of have they had pregnancy before, or have they tried, how long have they been trying for pregnancy? So you've got to keep those historic factors as well as what you find at the time of the surgery as well. So they may be saying 40-year-old woman, but if that's different, that's going to give a totally different score and a pregnancy outcome. But age itself is a very predictive, it's a very helpful tool in predicting pregnancy, but this is specifically in women with endometriosis undergoing surgery.
How do you treat IBS when it is diagnosis of exclusion? Sorry, if you'd like to continue, Dr. Chow, on that previous question.
That's okay. I was just trying to say, I think answer the IVF question, that's quite a complex one. I don't know if you can answer it all in the one session. You could probably do a whole lecture on that on its own. But I think, someone who's actually got quite severe endometriosis, IVF outcomes are not always that good. Now, I know that doesn't necessarily mean that you shouldn't try if that's the outcome measured, especially if they've got infertility. But IVF is not always the answer, and also that endometriosis doesn't equate that all women need to have IVF, and that's the value, I think, of the EFI as well, because you can, I guess, reassure some women that if you're not with a non-IVF cycle, that you have this ability to fall pregnant in this percentage, and I think that can be helpful as well.
So the next question was, how do you treat IBS when it is a diagnosis of exclusion?
IBS and irritable bowel syndrome?
Yes.
Karen or me?
I think Dr. Chow, you mentioned that earlier.
Yeah, sure. So I think it's quite similar to the endo question, because do you need to have the scope to be able to start managing your symptoms? And I guess the thing is that if you've got your red flag symptoms, So they've got blood in their stool, they've got mucus in the stool, they've got big changes in weight, they've got constitutional symptoms, etc., and you're thinking about inflammatory bowel disease, or you're thinking about cancers, then yes, okay, you need to have that scope. But if you don't have those things, I guess the question is similar to the endo pain question: is what is the harm in trying surgical management or non-scope management prior? And I know there's other things like celiac that are a little bit more insidious, and that's important to rule out as well. But if, say, for example, you look at dietary measures and lifestyle measures over 2-3 months, and the patient has a benefit, the question is, do you then need to have that scope? And I think, hopefully that answer to the question is that yes, it's important to be able to look out for those conditions that you don't want to miss. But if it doesn't look like symptomatic as the case, then you can start management, or while they're waiting for the colonoscope, start that management in any case.
Okay. Could you comment on HRT in women with past history of endometriosis?
I think we have to look at the benefit and the risks in those women and individualized treatment for how much is this going to benefit them. Generally speaking, if they had mild to, this is postmenopausal women. I suppose it's different for perimenopausal or postmenopausal women. Postmenopausal women, I think if they have really bothersome menopausal symptoms, and if the benefit seems high, I don't think we need to necessarily screen them for endometriosis worsening, but it should be part of the counselling process prior to commencing it, that it may be something that it may affect them to have pain. And that also applies not only to endometriosis, but other hormone-dependent disease such as fibroids or uterine adenomyosis as well. So it should be counselled for, but it's not a contraindication to commence someone on hormone replacement therapy.
I think to add to that, I think
keep going, sorry.
Oh no, I was just going to say that I think also for a lot of women, the big question is cancer risk. You know, Harry mentioned that, you know, this is 2% or 1.8% risk of cancer. So if you do, do you give them, if someone has been hysterectomized, can you give them stradition or not? Do you need to give them progestin? There is no answer to that. The literature is not clear. If you look at more cancer-based journals, they will give you all the case series of women who had unopposed estrogen with previous history of endometriosis who've ended up with peritoneal cancers and so forth. And so they'll say you should give a progestin or progesterone, and then you look at other stuff and they'll say, look, it's actually quite rare. So I don't think there is an answer to that at this stage from a research point of view. The other issue is that a lot of women with endo, you'll find, especially the ones that are the pointy end with a lot of pain, are progestin intolerant. So so that means the synthetic progestins they're intolerant to. And so a lot of these women, if you only give something progestin, or if you give something else, often prometrium or a micronized progesterone tends to work better as a rather than, or a low dose thing like a Mirena, rather than a straight progestin.
We will have to stop now. We have a lot of questions. Maybe we could send them through to you and you could answer them for us, and we could send it out to the group after the session's over. So, or we might be able to ask them again at the end of the next session, depending on how many questions we have. But I'd like to thank you, Dr. Wong and Dr. Chow. And I'll now ask our next speaker, Associate Professor Rhonda Farrell, to come online, and she will talk about the long-term impact of gynecological cancers.
Oh, hi, good evening. Thank you for joining us all tonight. Those two speakers gave wonderful presentations, and I hope you can learn something about the two most common gynecological cancers in my talk. I'm just going to show you my screen. So the two commonest gynecological cancers are endometrial and ovarian cancer. And so I'll focus on that tonight. So I'm Rhonda Farrell, I'm a VMO here at Prince of Wales Private Hospital, and I'm also a staff specialist at Lifehouse and a peritonectomy surgeon at Royal Prince Alfred Hospital. So the learning objectives tonight, I'll try and focus around how they relate to you all as a GP in primary care. I'll discuss some of the most relevant risk factors with opportunities for you to prevent these cancers out in the real world out there before women come to us. I'll also look at some of the tools to make a diagnosis in primary care, go through the management principles, a little bit about surgery, and look at what's new, particularly in ovarian cancer, because in the last 5 to 10 years we've made some great progress in ovarian cancer treatment and diagnosis and prevention. Just to put in perspective where gynecological cancers fit into cancers in women in Australia, as you probably know, the most common cancer is breast cancer, followed by bowel cancer. But as a group, the gynecological cancers make up 10% of all cancers in women. Uterine cancer is the most common type of gynecological cancer, and cancer of the ovary, unfortunately, is still a very common cause of mortality in women. It's the 5th most common cause of death due to cancer in women. Almost 3,000 women in Australia per year get uterine cancer, and that's really the only gynecological cancer that's increasing significantly in incidence, and that's because it's related to obesity, and there obviously is a big epidemic of obesity in developed countries. Ovary cancer, it's fairly stable in incidence. There might be a slight drop because women are having risk-reducing surgery. It still, as I said, is the most common cause of cancer death due to gynecological cancer. And then there's cervical and vaginal cancer, which are HPV-related cancers, which fortunately are decreasing in incidence. All of these cancers, as different groups, have different causal factors, which are really important for you to understand, because there's real opportunities for prevention of these cancers in primary care. So the most common cancer is cancer of the uterus, and when we talk about that, in most instances it's cancer of the lining of the endometrial cavity, or the endometrial cancer, which is a glandular cancer. And really that most of these, at least 80 or 90% of these cancers have a strong association with obesity in women. Interestingly, in fact, 20% of cancer deaths in women are related to obesity. And of all the cancers, particularly liver, colorectal cancer, they are really increasing in incidence due to weight gain in the population. But endometrial cancer has the highest relationship to obesity. For every 5 units of increase in BMI, there's a 4-fold increase in the risk of endometrial cancer. And it's really important because we can prevent endometrial cancer. We still don't really understand why obesity is so associated with endometrial cancer. There's certainly strong links with hyperestrogenism in these women. They make estrogen or estradiol in the fat cells from their aromatase enzymes. Even postmenopausal women who are overweight have excess levels of estrogen. But these women also have hyperinsulinemia and higher levels of adipokines associated with obesity. And it's particularly prevalent, as you know, in women with polycystic ovarian syndrome, because they don't ovulate regularly, and so they also have hyperinsulinemia, and they have a much higher risk of endometrial cancer. Particularly hyperinsulinemia and increase in cytokines causes inflammation in the endometrial tissue. And women have a progression from healthy endometrium over many years to hyperplasia and then cancer, similar to bowel polyps that start with benign polyps and can progress through the dysplasia stage to adenocarcinoma. And that's really important because it gives us great opportunity for prevention through weight loss and exercise, hormonal therapy, which I'll go through a little bit later, and chemo prevention with hormonal therapy and possibly metformin in obese women. So the second commonest cause of gynecological cancer is ovarian cancer, and this has a different causal factor. These are highly associated with genetic abnormalities that you've all heard of the BRCA gene, and there are BRCA-like genes, and about 50% of high-grade serous ovarian cancers are related to changes in the BRCA-like genes, which we can use to offer these women risk-reducing surgery if they have a strong family history or identified to be a BRCA carrier. And then, of course, the vaginal, cervix, and about 60% of vulva cancers are due to HPV infection. And with the new HPV vaccination, which in fact has been now for around for 14 years, believe it or not, we have noticed a big decrease in the incidence of high-grade precancers and starting to get a decrease in the incidence of these cancers. They're also associated with penile cancers, anal cancers, and as boys are vaccinated, there will be a decrease in those types of cancers too. But first cancer I'd like to focus on is endometrial cancer. It's reasonably common. Around 1 in 40 Australian women get endometrial cancer. And as you can see, the rising incidence there over the last 30 years is primarily due to obesity. About 80% are obesity related. However, if you look at the bottom line of this chart, there really hasn't been a reduction in mortality in these women, and that's because most deaths are actually due to cardiovascular disease and not due to the endometrial cancer. Most women with obesity-related endometrial cancer are cured with surgery. This is what obesity-related endometrial cancer looks like. It often presents early with a cancer in the inner half of the womb, and most of these women are cured with surgery. A smaller number, but not insignificant, around 15 to 20% of women have more aggressive cancers that aren't related to obesity, and often in addition to surgery need other treatments such as chemotherapy or radiotherapy, and these are more related to genetic mutations in the uterus such as P53 mutations. So what are the best diagnostic tools for endometrial cancer? Well, pretty much most cancers present with abnormal bleeding, but do beware of a woman with perimenopausal bleeding, a woman in her late 40s or early 50s who comes in with some irregular bleeding, still having periods, but they're becoming irregular. It's not always due to perimenopause. And if it's persistent, it definitely requires investigation. So the first mode of investigation is having a look, making sure that there's nothing else that's bleeding, such as the cervix or the vagina, and performing cytology. And if the woman hasn't had a HPV test in the last 5 years, performing a HPV test. The second crux of investigation, of course, is a transvaginal ultrasound. So what is abnormal when you're looking for endometrial cancer? In the postmenopausal woman, and that is a woman who hasn't had periods for 12 months, anything thicker than 4 millimeters is really abnormal in a woman not taking hormone replacement, and that really does require a biopsy. Women on tamoxifen for breast cancer, you can't rely on endometrial thickness. All of these women get cystic hyperplasia, which is a benign change. So if you're doing an ultrasound looking for something else and the woman doesn't have bleeding but she's on tamoxifen and she has a thickened endometrium, it doesn't require a biopsy unless that woman is having bleeding. How do we do a tissue biopsy? It's easier to do a papel biopsy on most women in the office. Some women have cervical stenosis and we can't get in to do that in the office, and they could have an outpatient hysteroscopy or inpatient hysteroscopy under an anaesthetic. Surgery for endometrial cancer is difficult because these women, as I said, are often very overweight with BMIs up to around 65. But the good news is that we now offer minimally invasive surgery to most of these women, such as through laparoscopy or robotic surgery performing a hysterectomy and staging. And so that has significantly decreased the complication rate, such as infection and blood clots and cardiorespiratory complications following surgery. Most women who have minimally invasive hysterectomies are in hospital for 1 or 2 nights and go home. This shows the robot at Prince of Wales Private Hospital, the surgeon's over on the left in the console, and the robotic arms, the patient is lying underneath the robotic arms, which are driven by the surgeon, but they offer great advantages in manipulative ability within the abdomen and pelvic cavity. And as you know, it's being used for other cancers of the oral cavity and bowel cancer. And it's a great setup here at Prince of Wales Private Hospital. The other new change in endometrial cancer over the last 5 years is the introduction of sentinel lymph node biopsy, similar to what is used in breast cancer. In the past, poor women like this had a 10 to 15% risk of severe lymphedema in the leg with taking out all the pelvic nodes for endometrial and cervix cancer. But now what we do is we use a dye called indocyanide green. We inject it into the cervix just before we go in surgically, and that's taken up by the first draining lymph node. And if we prove that that lymph node doesn't have any cancer in it, we don't need to remove all of the pelvic nodes. This is an infrared light on our scope that we shine onto that area that's been taken up by the dye, and it shows a beautiful green and shows us where the sentinel node is. Treatment following endometrial cancer. Most women, as I said, will require no other treatment apart from their hysterectomy. Younger women with endometrial cancer can safely retain their ovaries if they have an early grade 1 cancer, and it's a benefit to their long-term health. But most women will have their ovaries removed because they'll be over the age of 50. Early stage high-risk cancers will have volt brachytherapy over 3 to 4 sessions, but advanced stages often need chemotherapy and radiotherapy. So what are opportunities in primary care for these women? The first is in the area of prevention. Certainly to prevent endometrial cancer, the most important thing is women keeping their weight in a normal range, which obviously is easy to stay, but very hard to do. But there is good data from the WHI trial. Women only have to lose a small amount of weight, 5%. This was the study on 36,000 postmenopausal women, and women who managed to lose 5% or more of their weight had at least a 50% reduction in their long-term risk of endometrial cancer. So women only have to achieve small increments in weight loss to prevent cancers, not only endometrial cancers, but other types of cancers. It's important for the GP to know about Lynch syndrome. About 10% of women, particularly younger women with endometrial cancer, will be found to have Lynch syndrome. As you know, this is a defect in mismatch repair genes, which is associated with a strong lifetime risk of endometrial and colorectal cancer and ovarian cancer. What's very useful is the EVIQ guidelines, which can be found on the New South Wales Cancer Institute website. So really all patients in primary care ideally should have a family history taken. These are women that haven't developed cancer. And if a woman has, or a man has 3 first or second degree relatives with a related cancer, such as colorectal or endometrial cancer in their relatives, or just 2 first or second degree relatives with those types of cancer, and one of them happens to be young, you should refer them to the hereditary cancer clinic at Prince of Wales Hospital, or your local cancer clinic, hereditary cancer clinic, which are in all major hospitals, and they'll be offered genetic testing if appropriate and identify. And the biggest gain from this is preventing colorectal cancer through annual colonoscopy screening, as well as preventing other less common cancers in these patients, and offering family members to have testing as well. And finally, in prevention, women with PCOS who are anovulatory, the oral contraceptive pill or the Mirena is an effective way of preventing endometrial cancer. And there's some evidence for giving metformin to obese women that may prevent cancers as well. Women who have been diagnosed with endometrial cancer, it's important to manage their obesity. When they're diagnosed, it's a teachable moment where women are more open to making a lifestyle change. Most women will not die of endometrial cancer, they'll die of cardiovascular disease, so they need to have their cardiac risk factors assessed. And the most effective form of prevention for all cancers in obesity really has shown, particularly in the Swedish obesity study, to be bariatric surgery. I won't go into the share. GPs can share in follow-up with endometrial cancer. Cancer Australia has guidelines, and we really encourage general practitioners to share care of women in the community. And I'm sure Vivek later will talk about survivorship issues in these women, but the risk of recurrence for most women is low. Most recurrences will occur in the first 2 to 3 years, and women, pretty much most of them will present with some abnormal bleeding, and you can identify on a speculum exam. And part of the general follow-up is just looking. We no longer do volt smears in these women. You just have a look with a speculum. You check if they've had any abnormal bleeding, and it's important to manage their weight over time. The second shorter part of my talk is on ovarian cancer, and this relates to the most common type of cancer, the epithelial cancer, those cancers that you hear about that present late, most commonly high-grade serous cancers that occur in women around an average age of 60, and they present at late stage. It's often spread beyond the ovary to other tissues such as the bowel. This shows in many women it's spread to the upper abdomen. This is a very extensive cancer that's spread to the diaphragm and the liver. And in women with such extensive disease, nowadays we often give neoadjuvant chemotherapy before they have their surgery for ovarian cancer. The biggest change in our understanding of these ovarian cancers is most of these cancers do not arise from the ovary. They actually arise from the fimbrial ends of the fallopian tubes and high-grade serous cancers. That's why they can't be detected on any screening test, because basically they arrive from a precancerous change in the fimbria. The cells exfoliate out of the tubes onto the ovaries and you can't see them on an ultrasound, and they don't cause an increase in CA125. So screening is of absolutely no benefit in women. But what is women who are identified to have a high risk based on a hereditary cancer assessment, if they're a BRCA carrier or they've got a strong family history. The big thing that's saving them is risk-reducing surgery, removing their ovaries and tubes around the age of 40 or when they've completed their family. The second thing that's changed in ovarian cancer management is that we now approach these surgeries with more radical intent. I work in the peritoneectomy unit at RPA, and women with extensive advanced ovarian cancer, we do radical peritoneectomy surgery, which takes many hours, up to 10 or 12 hours sometimes, to remove all of the cancer. The evidence shows that you must remove all of the cancer to give them the best survival outcome. We now have evidence, that's our unit at RPA. What I'm showing there is HIPEC. So after surgery in these women, we give heated chemotherapy because there was a large international trial about 2 years ago that showed these women live a year longer if they're given HIPEC or hypothermic chemotherapy into the peritoneal cavity for 90 minutes following their surgery. So we offer that treatment in specialised centres in Australia. There's not many of them. There's 2 in New South Wales, St George and Royal Prince Alfred Hospital. And the final thing I'd like to talk about in ovarian cancer is our development of targeted treatments, particularly PARP inhibitors. I'm sure most of you have heard about these. A lot of women with ovarian cancer are getting them, as well as women with breast cancer. And there's even some recent evidence that bowel cancer is related to a BRCA. Can be related to BRCA mutations in the tissue. We know about 20% of women with high-grade ovarian cancers will have a hereditary BRCA gene mutation from their family, but in fact about 50% will have within the tumour, not hereditary from their mother or father, but within that tumour a BRCA-like mutation. And there's now developing very good evidence for giving PARP inhibitors for treatment, maintenance treatment of these women after their chemotherapy for ovarian cancer. It's subsidised by the PBS for women who have the germline mutation that's come from their mother or their father, but you can get compassionate access from AstraZeneca company for women who have the somatic mutation. So we now send tissue for testing for BRCA gene-like mutations within that tissue. There are side effects of PARP inhibitors, particularly anemia in women, and about 1% can get acute leukemia, so it's not without risk, but the evidence shows it significantly improves survival in these women. So in summary, endometrial cancer is the commonest gynaecological cancer. Abnormal bleeding should always be investigated if it's persistent, and the key to saving women's lives with endometrial cancer in most instances is managing obesity, and that's really you're best at doing that out in the community. With ovarian cancer, there is absolutely no role for screening women at risk with regular ultrasounds and CA125s, but there is importance of high quality surgery, collaborative surgery in units, in tertiary units, and there's an increasing importance of looking for BRCA or BRCA mutations in the tissue for offering these women PARP inhibitors as treatment. So if you'd just like to send any questions through to Susan or Lauren, and I'm very happy to answer them.
Speaker is Dr. Vivek Arora, and he will be speaking on quality of life and the long-term impact of gynecological cancers. Thank you.
Hi, everyone. Thank you, Susan and Rhonda. I guess I've got the interesting job of keeping everyone engaged in this final 30 minutes of presentation with rather difficult topic of survivorship following gynecological cancer. I'm a gynecological oncologist, and apart from the usual complex gynecological, laparoscopic, and cancer surgery, I have a strong focus on holistic care and quality of life after treatment for gynecological cancer. And when I started researching for this talk, this was one of the first things that I came across as editorial. And just the first line, Doc, should I see you or my oncologist, pretty much captures the essence of my talk today. To me, it's not a rhetorical question, it's a very real question that the reverse of this is what we get asked in our clinics. And I'm sure most of you, if not all of you, have been asked this question because there is a significant overlap apart from the surveillance of the primary cancer on who should manage what. And the little figure that I put on the side pretty much reflects of how these women end up getting managed with the gynaecologist and the GPs. And it's not just gynaecologists, you should probably say it for all cancer specialists, the communication going in opposite directions and not always achieving resolution. So a plan for my presentation is that I'm going to discuss cancer survivorship, in particular gynecological cancer survivorship. I've chosen 3.5 topics to discuss, 3.5, chronic fatigue being would be the shortest section of this presentation, and that we are most likely to encounter after treatment for gynecological cancer in both specialist and general practice. And all these things are rather difficult to manage. And I'll have a very brief discussion on post-treatment surveillance for gynecological cancers. So cancer survivorship is the process of living with, through, and beyond cancer that starts pretty much at the diagnosis and continues for the rest of the woman's life. And this would include women who are on active treatment, those who are on maintenance treatments, those who are considered cured and are living with chronic disease, either that was pre-existing or acquired during the course of this treatment, and not to leave out those who have been diagnosed with recurrence and are on subsequent treatments. The transition from cancer treatment to cancer survivorship is a time for celebration and relief, but it is also a time that we need to discuss so many different aspects of cancer care, including acute and late toxicities, empowering the women to seek reviews if they have any concerns. We need to keep on discussing ongoing cancer surveillance, which in itself is shown to cause significant psychological morbidity. There is a need for maintenance of overall health and to deal with psychosexual issues resulting from cancer diagnosis and treatment. And this, as we will see, is a whole Pandora's box in itself. And the aim of all this is to return to some semblance of normalcy, or the new normal, as I would call them, for these women, and which includes normalcy in life, normalcy in the daily routines, an attempt to return to the pre-morbid state, including employment. High survivorship with gynecological cancers compared to other cancers means that chronic conditions like obesity, diabetes, and cardiovascular disease become a bigger threat. Additionally, menopause resulting from the treatment is itself a significant risk factor for cardiovascular disease in women. And it is a known fact that too much emphasis on cancer surveillance shifts the focus away from preventable morbidity and mortality secondary to these chronic conditions. Before we go on to the individual conditions we're going to discuss, I just wanted to highlight in this particular figure that an important aspect of gynecological surgery. On the left, we can see the inferior hypogastric nerves as identified by the yellow lines that run inferior and parallel to the ureter in the broad ligament along the uterosacral ligaments. These nerves are damaged to some extent in any pelvic surgery, especially hysterectomy, even for benign conditions, and is the reason for a lot of the postoperative morbidity. As the complexity of the surgery increases and the radicality, like for cervix cancer, in which we have to remove a part of the uterosacral ligaments and the cardinal ligaments, the degree of damage to these nerves increases, thus resulting in increased morbidity and the complications that we're going to discuss today. We'll start with bowel and bladder dysfunction after hysterectomy, and as I mentioned, that a lot of it is related to the disruption of autonomic nerves running in the inferior hypogastric nerve plexus and the inferior hypogastric nerves. Surgery itself results in low bladder compliance, detrusor instability due to the imbalance of parasympathetic and sympathetic nerve innervation. It is very common to experience constipation after hysterectomy, partly because of the impact on the inferior hypogastric nerves and partly because of the postoperative. As I was mentioning about constipation being a very common side effect of hysterectomy related both to the surgical disruption of the inferior hypogastric nerves and postoperative analgesia. And as you'd see from this graph on the right, this was a landmark study that showed that the rates of incontinence surgery, urinary incontinence surgery, are double after hysterectomy. And urodynamic studies have been shown to be abnormal for as long as 6 weeks after a hysterectomy and start to improve only by 3 months post-surgery. Another interesting fact is as many as half of the women undergoing hysterectomy have pre-existing urinary incontinence. Paradoxically, women who have higher severity of urinary incontinence report improvement in the symptoms, whilst those with mild symptoms prior to the surgery are likely to report worse symptoms of urinary incontinence after the surgery. So the take-home message from this is that bowel and bladder dysfunction is more common than is usually perceived after pelvic surgery. It may not always have a significant impact on quality of life, but that's usually because women are unlikely to report it unless they're questioned specifically about bowel and bladder dysfunction. My usual approach is to start with reassurance, particularly if they haven't reported significant worsening in the pre-morbid symptoms, or if they haven't reported any new urinary or bowel incontinence. It can take as long as 12 months after a radical hysterectomy for constipation to start resolving. We need to give advice on diet modification, increasing fiber in the diet, using laxatives judiciously and avoiding senna especially, and most importantly, advising weight loss in obese women, which is a significant factor with urinary incontinence. Those who have reported significant worsening should be referred for pelvic floor physiotherapy and or a urogynecologist at an early stage. And just a note of caution over here is that any new onset bowel and bladder dysfunction in a woman who is being followed up for gynecological cancer could be indicative of recurrent disease and thus should be investigated thoroughly. Lower limb lymphedema is another difficult condition that we encounter, and again, probably more frequently than was previously perceived. There is no standard definition for lower limb lymphedema, which means that the literature is heterogeneous on its actual incidence. Unlike women who've been treated for breast cancer, leg lymphedema is usually bilateral, so there is no reference limb for measurements. And we only take preoperative measurements in research context. Generally, we quote a background population risk, or we have always quoted a background population risk of 2 to 5% because of other factors like chronic venous insufficiency. And after pelvic lymph node dissection without pelvic radiotherapy, it's around 20%, possibly increasing to about 40% if they also have pelvic radiotherapy. Groin lymph node dissection causes much higher incidence of lymphedema, which involves not only the legs, but involves the lower abdomen and the groin and hip region. And if they receive groin radiotherapy after groin node dissection, the incidence of lymphedema is almost universal. Extensive lymph node dissection, as opposed to sentinel lymph node detection, has a much higher incidence of lymphedema. And any pre-existing lymphedema prior to the starting of treatment is a significant risk factor. Increasing age and obesity are further contributory factors to development of lymphedema, as well as adjuvant treatment after surgery. Insufficient physical activity prior to the surgery is an independent risk factor for developing postoperative lymphedema. And the interesting thing is, as we all know, that these women are also at high risk of other comorbidities like type 2 diabetes and cardiovascular disease. Even women who were previously advised of the risk of the lymphedema describe feeling lonely and betrayed when they are diagnosed with postoperative lower limb lymphedema. It has impact on physical activity and activities of daily living and the ability to return to employment. There's additional cost associated with lymphedema with the rehabilitation, needing new clothes to cover up, requiring shoes in 2 sizes with unequal foot size. It has significant impact on body image, resulting in loss of intimacy with the partner and contributing to depression and lack of sleep. Women also associate postoperative lymphedema with the likelihood of recurrence of the cancer. This was a very important prospective, and the first prospective study, that was an Australian study that noted that as many as 1 in 6 women reported lymphedema or self-reported lymphedema at presentation with gynecological cancer prior to the start of the treatment. And when they had objective measurement with this spectroscopic method, as many as 1 in 4 had measurable evidence of lymphedema at diagnosis. And 2 years after surgery, nearly half of the women had evidence of measurable or self-reported lymphedema. Now, this is a slightly higher incidence of lymphedema as opposed to the traditional literature, but the measurement of the assessment of lymphedema was using a spectroscopic method, which was much more sensitive than just measuring the limb circumference. And a consistent finding across the literature is that 3/4 of lymphedema would present within the first 12 months of treatment. Prevention is definitely better than cure with lymphedema, and it starts with individualizing surgical treatment plan in women once the risk factors are identified at presentation, like presence of chronic venous insufficiency, an occupation that involves standing for prolonged periods, and of course, patient attitude towards the risk of lymphedema. Just quoting the risk is not enough. If a particular patient would say, I have had patients who would say, I would rather take a slightly increased risk of missing disease with the sentinel lymph node or not having lymph node dissection than having even a slight risk of lymphedema. And that is something that you have to factor into account. We need to educate women at multiple points on lymphedema after the surgery, because anecdotally I have noticed that women tend to forget about lymphedema because all the focus is on cancer and getting back from getting better from the cancer, getting better from the toxicity of the treatment, especially if they're having radiotherapy or chemotherapy. I personally refer even women who have had sentinel lymph node detection for lymphedema education, and that is especially after the LIC study results came out, because we're probably underestimating the incidence and the impact of lymphedema in the community. And this is again a service that is grossly underfunded in Australia, and referring more patients is likely to generate more. It's about more resource generation and being able to provide adequate service to these women. Psychosexual health after gynecological cancer treatment is probably one of the least discussed topics, even in the gynecological oncology community. And as we will see that as many as 43% of women have reported sexual dysfunction at some point in their lives in the general population. And this incidence is almost universal following treatment for gynecological cancer, which is not surprising because the treatment essentially involves the femininity or the organs associated with femininity, loss of female organs, and their impact on the sexual function because of vaginal shortening or vaginal dryness, and especially the vulval surgery being a point in case, results in significant body image and physical issues. Surgical menopause from the loss of ovaries has a further impact on libido and a physical impact on sexual functioning, which only gets worse if they receive adjuvant treatment in the form of radiotherapy or develop complications like lymphedema or bowel and bladder issues. Jason, I've blatantly lifted up this figure from your website because it just describes the genitofemoral nerve distribution so well. And this is where in this survey, the reported issues related to sexual dysfunction include lack of sexual interest after treatment for gynecological cancer, lymphedema, genital numbness in as many as 3 out of 4 women, which is related to the damage to the genital branch of the genitofemoral nerve, which anesthetizes or causes paresthesia in this region. And you can very well see how that would be distressing to the woman. Poor vaginal lubrication is also associated with damage to the inferior hypogastric nerves, as we previously noted. Radiotherapy causes further damage to the vaginal tissues in the form of shortening, agglutination, and fibrosis, which results in dyspareunia or apyreunia in worst cases. 3 out of 4 women actually want to discuss sexual function with the physicians, but very rarely does it actually get discussed, especially prior to the start of the treatment. And of course, the usual blame goes on lack of time, but the real reason is lack of training and skills, an embarrassment both on the part of the gynecologist on broaching the topic or worrying about embarrassing the patients if the topic is broached up. But most importantly, I think it is related to underestimation of the sexual dysfunction in the general population, and also underestimating the impact of sexual dysfunction on overall health and well-being. And when we're talking about the time on discussing, it's not entirely without merit, because if we only see the woman and the impact of gynecological cancer on the woman, we are only seeing half of the picture, because as you can see in this interactive model, half of the things, issues that may be related to sexual dysfunction are possibly partner related, and which never would get discussed in a clinic either, definitely not in gynecological oncology clinic. I can assure you that. I'm not proud of it, but it is very, there certainly is not enough time. And I would not really expect a general practitioner either to be able to approach it up in an appointment that is supposed to discuss several other things, and therefore it requires a very focused discussion. But the most important thing is to acknowledge the importance of and to inquire into sexual function, and I would definitely try to do that. And it's very interesting when I do that, the kind of responses that I get, and they range from yes, we are trying, yes, we are struggling with this, and I try and address those, to those, okay, I don't want to discuss it, or no, this is a marriage of convenience, I would not like this to broach it up, and when I make a little note and not to bring it up in those cases. But we need to try and make an effort to identify the cause, educate the patients on vaginal dilators, normalize the use of dilators after radiotherapy, and the use of lubricants and moisturizers are simple interventions. We often forget vaginal estrogens, even in apparent hormone-sensitive situations, but it does require involvement of psychologists or sexual health counselors. But the most important thing is to start the conversation, and this is a brief sexual symptom checklist for women, which would only take a couple of minutes for them to go through, but it makes it a lot easier to broach up the topic and to start focusing on what might be the cause of the sexual dysfunction and to start working on that. This would be a very short section on chronic fatigue, because probably one of the most complex things, but very little objective interventions, partly because it is multifactorial. It is a common symptom in several cancers, and an interesting thing was a quarter of women were reporting chronic fatigue even 11 years, a decade after the diagnosis. Not surprisingly, it is much higher in women who are receiving chemotherapy or radiotherapy, but even women with who had only had treatment with cone biopsy, they have reported chronic fatigue. So it is related to some extent just the diagnosis of cancer, and also then related to other factors that we have discussed before, like sexual dysfunction, the impact of diagnosis of cancer, bowel and bladder dysfunction. I think the first thing is to acknowledge that it is normal, it is acceptable to experience chronic fatigue after a diagnosis of cancer. Try and identify any associated factors and try and rectify them before we seek psychological support. Post-treatment surveillance, just a very few very quick points. There is no role for routine imaging or routine testing in post-treatment surveillance because it has poor sensitivity and poor specificity. 3/4 of women would present with symptoms in between the appointments, and therefore should be empowered to seek either an appointment with a GP or the specialist if they have any concerns. Routine testing leads to more invasive interventions, but not necessarily an earlier diagnosis of recurrence. The notion that to pick up the recurrence early would result in higher cure rates has not been borne out in randomized controlled trials. Recurrent disease almost always presents with symptoms, and investigations that are carried out in response to new onset symptoms have a much higher sensitivity and specificity in diagnosing recurrence. And I would usually advise women that this would be my standard statement to them, that please contact us if you experience any new persistent or progressive symptoms that are explained by dodgy weather or dodgy food. hopefully we're trying to discuss these issues. We can change the model of care that we are providing to these women from the one that I showed previously, in which everyone is going in a different direction, to one that encourages conversation, communication, and interaction at multiple points and as an ongoing thing in care of these women. Thank you, and be happy to answer any questions or be contacted for any questions. Or Susan, over to you.
Thank you very much, Dr. Arora. Professor Farrell, sorry, if you could come back on now, that would be great. We do have a few questions for you both. Thank you. Okay, our first question. Can you please comment on the role of HPV vaccinations in already sexually active women, as well as women who are already HPV positive?
I'm happy to comment on that. So, as you know, it's highly recommended that women have the HPV vaccination hopefully before they become sexually active, but there is still benefit in women after that time. There's at least 15 different types of high and intermediate risk HPV. So women who are still particularly under the age of 40, who haven't met their long-term partner, who are sexually active, even if they do have been detected with a HPV 16 or a HPV 18 or a non-HPV 16 18, I do discuss the role of vaccination with them. There is evidence that it is effective in women up to probably the age of 40 or mid-40s. They still have an immune response with a vaccine. It's probably not as good as women in their teens to early 20s, but they still can benefit from the vaccine. Women who are monogamous, who have had a long-term partner, who see me for an abnormal cervical screening test, I talk about the risks and the benefits. I talk about the fact that if they're monogamous and they're going to stay that way, their partner is monogamous, they may not get the same benefit from the vaccine as women who will have multiple partners in the future, and it comes at some cost, and I let them make that decision and advise them to try and discuss it also with the GP. And I give them a handout about the Gardasil 9 vaccine as well.
Thank you. The next question, how common is it to see patients with breast cancer who have been on agents like tamoxifen for prevention of recurrence of breast cancer responsible for endometrial cancer? Either
Vivek,
of you.
Do you want to answer that, or?
I think the numbers are 1 out of 625 women, I think, who've been on tamoxifen will develop endometrial cancer. So the number, it does slightly possibly increase the risk of endometrial cancer, or it has been associated with it. But the benefit of the tamoxifen in reducing the risk of breast cancer is way higher than the risk of endometrial cancer developing in these women. So on the balance of those, they have to be, they would err to stay on tamoxifen rather than come off it.
Yeah, the tamoxifen increases your risk of endometrial cancer 3 times the background risk, so that's 3 by 1 in 50, which is still only 3 in 50. And most women who get tamoxifen-induced endometrial cancer presents early. So, but a woman on tamoxifen who has any abnormal bleeding or discharge should be thoroughly investigated with a biopsy. You can't rely on an ultrasound because they'll all have a thickened endometrium.
Thank you. The next question, women who have a past history of ovarian cancer, how often do we do tumour markers, CA125, and how specific is it?
So the specificity relates to the fact that most of these women have had their ovaries removed, so they're menopausal, so it's actually quite a reliable marker of recurrence. And it depends how long out from their treatment. Usually In the first year, we do it 3 monthly, in the second year, 4 monthly, 6 monthly, and then yearly. However, it must be remembered that the evidence doesn't show increased survival by measuring CA25. It shows that you detect a recurrence earlier, but it doesn't show an improvement in their survival if you treat them earlier. But many women want it done because they're, become very anxious about the fact that they might have recurrence. And whether survival will improve with new targeted treatments if the cancer is detected early, we don't have that information yet. Many women with recurrence aren't suitable to have secondary cytoreductive surgery, but there are occasional cases where if you detect it early when they've just got one pelvic recurrence or something that you can remove surgically, that one woman might have a survival benefit. So in summary, it hasn't been shown to improve survival by doing regular C125s, but women generally want it, and there may be an occasional woman that might benefit but from an early detection.
Thank you. The next question is, do women who have had a full hysterectomy for endometrial cancer or for benign reasons, example fibroids, need Volt smears?
No, no, we don't recommend any Volt smears because only for endometrial cancer, if you did Volt smears, only 7% of all recurrences will ever be picked up with a Volt smear. And that means you're probably doing over 100,000 smears to pick up one endometrial cancer. As it has not been borne out to be a good follow-up test, it has been something that's been done traditionally, but we backed out of it because it is too much reliance on it, and especially women, if they've received radiotherapy, Volt smears leads to misinterpretation and more interventions. For women who have had benign hysterectomy for benign causes, there is no role for Volt smears if their smear history was negative and there was no evidence of cervical dysplasia on the found pathology specimen. Only women who had dysplasia on the final hysterectomy specimen require follow-up smears, and they possibly require it lifelong, or they've got a significant history of abnormal smears of persistent HPV in the past. Rhonda, do you think that's fair enough? Or?
Yeah, no, that's a very good summary. And the only women we do Volt smears on who have had those conditions are women who have been detected as having high-risk HPV or intermediate risk HPV as part of the ongoing screening for vaginal precancers and cancers related to HPV, but it's not a benefit for endometrial cancer, the detection of recurrence.
Thank you. The next question, any role for hysterectomy in an obese postmenopausal woman with thickened endometrium but no malignancy on DNC?
Oh, well, if a woman has one of the precursors such as complex hyperplasia or complex atypical hyperplasia, we generally recommend a hysterectomy because up to 30% of those women will have a cancer we haven't detected on the DNC. If a woman has simple hyperplasia and is at that very beginning of that spectrum of progression, if they're very overweight and not fit for surgery, we'd probably elect to put in a Mirena IUD rather than a hysterectomy because of the risk of surgery. But as a preventative, if they have younger women with polycystic ovarian syndrome, yes, because they are at higher risk of endometrial cancer and they will continue to have a lifetime risk. But unless a woman has ongoing bleeding, we wouldn't recommend a hysterectomy without any proven cancer, but you would see them regularly and certainly send them back to the GP with a strong advice that if they had abnormal bleeding or discharge that they are investigated. Unless they have a family history of Lynch syndrome, then they may be offered risk-reducing surgery if they themselves have Lynch, are tested and be positive for Lynch syndrome. Of course, that's a preventative method for endometrial cancer.
Thank you. Next question. If no benefit for CA125 and ultrasounds to detect ovarian cancer, is there any other screening test? For example, CT abdomen?
No.
Well, screening test is on asymptomatic women, so unfortunately not, but there is a lot of research going into a blood test looking at circulating tumour-free DNA at present, which is showing promising results. But the only thing that we can say to women at high risk of the ovarian cancer is to get your ovaries and tubes out, really, as a prevention, and warn them of the symptoms.
Thank
Well, I
you.
think sorry,
Sorry,
Susan.
go ahead.
I was just going to complement your answer on that. I think you just need to emphasize repeatedly there is no screening strategy for ovarian cancer. I did every now and then when looking at something on the Google, you come across someone offering ovarian cancer screening, but there is no screening strategy for ovarian cancer. We have not yet come up with a test that is that has got sensitivity or specificity high enough to justify, and what that leads is to more operative interventions, like from the PCLO study, 19 women would undergo a major surgery to diagnose one ovarian cancer, and similar results were from the biggest study, the UK CTOX study, is that similar numbers. And whilst they did pick up extra ovarian cancer cases, it did not exactly result in stage migration or improvement in survival. So currently we do not have any ovarian cancer strategy.
Next question. Could you please comment on the relationship of endometriosis and CA125?
CA125 is raised in many different conditions, which includes pregnancy, fibroids, having a period, having a cough, sneezing, any kind of itis. It is a glycoprotein that is produced by the coelomic epithelium, which lines all the visceral organs, so pleura, pericardium, peritoneum. So any itis, pleuritis, pericarditis, peritonitis, UTIs, pancreatitis, along with ovarian cancer, cause a rise in CA125. CA125 is only raised in 80% of ovarian cancers and not all ovarian cancers. Endometriosis is a condition that typically irritates the peritoneum and can result in very high levels of endometriosis. The highest one that I have come across was 6,700, which was just endometriosis and nothing else. So yes, it does, and the mechanism is by peritoneal irritation, which causes the release of this glycoprotein in the blood, and hence the rise. And it could be a rise, mild rise, or it could be as high as in thousands. So it is an excellent but a very rubbish marker, because it doesn't distinguish between benign and malignant conditions. In the absence of other features, it is an excellent tumor marker for follow-up. And if you look at the FDA recommendations from US, it is only recommended for follow-up and not for diagnosis. So it's that is why you have to interpret CA125 very carefully, and that is why you shouldn't be doing it in asymptomatic women for screening.
Thank you. A question for Dr. Farrell. Does robotic surgery reduce the risk of damage to the hypogastric nerves and post-op pain and morbidities to bladder and bowel?
That's a very good question. If you listen to the Da Vinci company, they say yes, but there's absolutely no evidence. The benefit of robotic surgery is in the ability to operate on morbidly obese women, particularly those with endometrial cancer, to actually be able to do the surgery, because of there's about 7 degrees of freedom in a robotic instrument compared to about 3 in a laparoscopic instrument. So you can get down in small spaces with the robotic arms and have multiple arms to help you. But apart from making the surgery a bit easier for the surgeon and looking after the surgeon's back, and helping us to be able to operate on morbidly obese women, I don't believe there's any benefit in post-op pain or in decreased complications.
Thank you.
From my experience and from the evidence, there's no improvement in oncological outcomes with robotic surgery as yet, and shorter stay, all of the studies compare robotic surgery with laparotomy, not so much with laparoscopy. So I don't think there's any significant benefit to hospital stay, but it certainly is of benefit in particularly morbidly obese women. And I'm talking about endometrial and gynaecological cancer, not bowel cancer and other cancers where there may well be a benefit.
Okay, the next question is, can you comment on the safety of vaginal estrogen after treatment for breast cancer or other gynae cancers?
I know about very much about breast cancer. There was a large recent meta-analysis published in Lancet 2 years ago that showed that vaginal estrogen, there was absolutely no increased risk in women for breast cancer who have had breast cancer for their recurrence, or women who are at risk of breast cancer. We do use it for women who have had endometrial cancer, and there's no evidence that it's not that it's detrimental to their survival. There hasn't been large randomised controlled studies in women with gynaecological cancer, but we avoid most estrogens, particularly systemic estrogens, in women who have estrogen responsive cancers, particularly if they still have disease left in or they've had late stage disease. But vaginal estrogen is relatively safe for most cancers, including breast cancer, according to the evidence. Vivek, do you have any other thing to add to that?
Oh, no, I completely agree. And the data on systemic absorption, systemic levels over a prolonged period of time is available only up to 12 months of use. So I always mention that when we're having these discussions, but I think it is quite safe in long term. The data from a retrospective study in use of HRT in women with endometrial cancer did not bear out increased risk of recurrence. I noticed while doing this topic is that breast cancer, on Cancer Australia website for breast cancer, they still say avoid, do not use vaginal estrogen, but I think that is pretty unfair on the women. What I do want to highlight is that you do not need to use the whole applicator full to avoid genitourinary syndrome related to lack of estrogen. All they need to use is about a quarter of that dose, or just about on the fingertip, and applying just under the urethral region, and that is pretty much enough to deal with the symptoms. And then if it's not helping, they can increase the dose slightly. But to start with the dose as it comes in the applicator full for 3 weeks, and then go down to the quarter of that dose and applying it just at the introitus. Long term, so you're giving much lesser dose and possibly much lesser systemic absorption, and still an effective management of the genitourinary syndrome related to the lack of estrogen. And we'll never get a high quality evidence unless we study 10,000, 100,000 women in this, and which we're never going to get in the near future. Hopefully someone does, but it's not going to happen in Australia with our populations. It'll obviously be somewhere from a country with a bigger population. But what I just want to highlight for our colleagues is that explaining to the patient, you don't need to use the whole applicator full, which also then lasts a lot longer. But I always tell my patients, don't tell the pharmacist how you're going to use it, because they go a bit berserk. They don't like off-label use of medications.
Thank you. This might be our last question as it's getting a bit late. For hormonal control of endometriosis symptoms of the contraceptive pills, which would be more appropriate for these endometriosis patients?
Which contraceptive pill?
Yes.
Yeah, look, I try and avoid endometriosis, so I'm probably not the best person to ask, but I don't think there's a lot of evidence that that any of them are any better. There's newer ones called Valette with a newer progestogen, but I think I don't know of any evidence that show any difference to really any of them. That's the side effect profile, I suppose. That's the most important thing, and it's very much an individual thing. Side effect, I've found some women have side effects with some types of progestogens and not with others, and sometimes it's a trial and error approach as to which pill you would use. Jason might want to answer that because you treat more women with endometriosis than either of us, thank goodness.
No, thank you. I just popped back on, but I think you break it down to whether you want to prevent endometriosis as a endometriosis lesion issue, or you're trying to, what's the best to manage the pain. So if you're looking at it from a practical point of view, Rhonda's right, that there probably isn't one superior to another. So you've got to find the one that has the best fit for the patient. And I think when it comes down to it, some women do better when you try to skip cycles, and in that circumstance you're trying to find that right fit for that person. So that could be the Mirena, or it could be taking whichever pill continuously. Now, some young women don't tolerate the larger doses of the old school combined oral contraceptive pills because they're a little bit more androgenic, and some women don't tolerate progestins generally, and that's also quite tricky. So then you've got to try and go low dose, but then you don't get the amenorrhea. So I think it's trying to find that right fit, but not one more than another. I think some of the women who have a lot of pain issues will find that anything which gives them a lot of breakthrough bleeding is troublesome. And also some women who are very sensitized will find that things like the Mirena won't just be, a few days turnover in terms of recovery. They could be cramping for weeks, or sometimes is what they describe. So no specific, but I think what's best for the patient in that combination.
I'd like to thank you all at this point in time.